Welcome to this explainer on pediatric neurology. If you're looking to crush your upcoming quizzes and master high-yield ATI-style clinical scenarios, you are in the exact right place. Today, we're doing a rapid-fire question-and-answer review of critical pediatric neuro and sensory assessments. We'll be drilling down hard on safety alerts, critical thinking, and priority nursing interventions. Okay, let's dive right into this. Here's our clinical checklist. We're covering the pediatric neuro exam, sensory dysfunctions of the ears and eyes, the life-threatening crises of increased ICP, seizure recognition and response, and finally, long-term neurological care. Let's get started. Section 1. The Pediatric Neuro Assessment. All right, first high-yield question for you. Why is a pediatric neurocheck completely different from an adult's? Seriously, think about it for a second. You can't exactly ask a newborn to squeeze your fingers on command or tell you on a scale of 1 to 10 how bad their headache is, right? Well, structurally, a child's neural tubes are literally still fusing, and they have open fontanelles. Their myelin sheath is still developing, which means nerve conductions are much slower, and because an infant just can't communicate those subtle symptoms, here is your next quiz question. When assessing an infant's neurological health, what is your primary indicator? The answer? You should be looking for the presence and the appropriate disappearance of newborn reflexes. These anatomical differences are exactly what make kids uniquely vulnerable to rapid decline. So how do we assess cranial nerves in a totally nonverbal infant? Let's test your knowledge again. To assess cranial nerve 5, the trigeminal nerve, what do you look for? You'd observe their rooting and sucking reflex. What about cranial nerve 7, the facial nerve? That one's easy. Simply check for facial symmetry when the baby is crying. Let's level up to priority interventions. Imagine a child has dysfunction of cranial nerve 10, the vagus nerve, causing difficulty swallowing. What is your priority nursing intervention here? You absolutely must assess for aspiration and provide a safe means of communication. Now, what if they have damage to cranial nerve 12, the hypoglossal nerve? Your priority is to have suction ready right at the bedside and closely observe their ability to chew and swallow. These are massive, high-yield safety priorities you need to know. Moving right along to Section 2, sensory dysfunctions, ears and eyes. These sensory organs are the main inputs for a child's development. Here is a highly tested procedure alert question. If you're administering eardrops to a 10-month-old infant, how exactly should you position the ear? The answer? Gently pull the pinna down and back. Why? Because an infant's eustachian tube is shorter, wider, and straighter than an adult's. Now, if the child is over 3 years old, you pull the pinna up and back to straighten the canal. Definitely do not mix those two up on a quiz. Okay, moving to eye assessments, let's talk about strabismus or crossed eyes. Question: what is the primary treatment goal for a child with non-paralytic strabismus, and how do you achieve it? Your main goal is to prevent permanent vision loss, which is known as amblyopia, and you achieve this through occlusion therapy. That means you patch the good eye to force the weaker, affected eye to work harder. Early intervention here is absolutely critical. Now imagine you're doing a routine neurocheck. You shine a light into a child's eyes, and you notice the sudden appearance of a fixed and dilated pupil. What is your very next action? The correct answer is you report it immediately. This is not a wait-and-see situation. It's an absolute neurological emergency indicating possible brain herniation. You don't just document and monitor, you stop everything and act. That brings us to Section 3, brain under pressure, increased ICP. We are stepping into life-threatening territory now. You absolutely must memorize these early warning signs. Quiz time. What indicates early increased intracranial pressure in an infant? You want to look for a bulging anterior fontanelle, a high-pitched cry, and extreme irritability. Catching these early signs is crucial, because once vital signs actually start to change, you're already dealing with late, severe hypoxia and potential brain damage. Systemically, things can escalate super quickly. If a child with a head injury develops a decreased pulse, irregular respirations, and increased blood pressure, what do those specific deviations indicate? That triad is Cushing's response. It's a late and highly ominous sign of increased ICP, and it's usually accompanied by severe lethargy, decreased motor responses, and sluggish pupils. All right, here is a stop everything and act priority scenario. A lethargic pediatric patient arrives at the clinic and suddenly develops a rash containing petechia. What should you suspect, and what is your priority action? You should immediately suspect a meningococcal infection, and your top priority is immediate isolation and referral for critical care. That specific rash indicates bleeding under the skin from severe sepsis. It's a massive red flag. Next question. What if a child with suspected bacterial meningitis starts exhibiting involuntary arching of the back and extreme extension of the neck? What is the specific posture called, and what precautions should you initiate? This is known as the opisthotonous position. As the nurse, your immediate priority is to initiate droplet precautions and prepare to administer intravenous antibiotics. Let's stick with posturing and test your knowledge a bit more. You observe a patient with all 4 limbs extended and the hands pronated right after a severe head injury. What does this indicate? This is called decerebrate, or extensor posturing, and it points to a severe brainstem injury. This is a highly critical finding that means you need to notify the provider instantly. On the flip side, decorticate posturing, where the arms are flexed inward to the core, indicates a cerebral cortex injury. Both are really bad news, but decerebrate is an absolute emergency. Section 4. Seizure recognition and response. This whole topic is the ultimate test of your ability to stay calm and prioritize patient safety. Here's your scenario. A child begins having a generalized tonic-clonic seizure right in their hospital bed. What is your very first action? The answer: maintain a patent airway and turn the child on their side. Follow-up question: should you insert a padded tongue blade to protect their airway? No, absolutely not. Never put anything in a seizing patient's mouth and never try to restrain them. You just clear the area of hazards and closely observe. You also have to know exactly when a standard seizure crosses the line into a medical emergency. If a child has been seizing continuously without waking up, at what point does this become status epilepticus? The answer is when the seizure is prolonged and doesn't respond to treatment for 30 minutes or more. The massive risk here is life-threatening brain hypoxia, which often requires mechanical ventilation and IV meds like diazepam or lorazepam. It's also super important to understand the anticonvulsant meds we'll use. If a child is prescribed phenytoin, which you might know as Dilantin, what specific education must you give the parents? Well, you have to teach them meticulous oral hygiene. Why? Because phenytoin causes gum hyperplasia, meaning an overgrowth of the gums. Also, make sure they know it should never be given with milk. And our final section, Section 5, Long-Term Neurological Care. Let's talk about protecting safety over the long haul. For a child with a neuromuscular condition, just eating a meal is a high-risk activity. Scenario: when feeding a child with cerebral palsy who has a known hyperactive bite reflex, what specific equipment modification do you need? The answer: use rubber-coated spoons. This prevents the child from injuring their teeth and mouth if they bite down hard. You also must avoid tilting their head back so you don't cause aspiration. Here is a classic vital safety teaching point. A parent asks if they can give their 5-year-old some aspirin for a fever caused by the chickenpox. What is your exact response? You must strongly instruct that parent never to give aspirin or salicylates to a child with a viral illness. This is the primary way we prevent Rey syndrome, which causes acute, dangerous encephalopathy and severe liver damage. We'll wrap up today's explainer with this quote. Careful clinical assessment is essential. The nurse continues to monitor the child's neurological status and to record and report subtle changes. I want you to really reflect on this. Your vigilant critical thinking, your ability to catch that slightly bulging fontanelle, or your quick reflex to turn a seizing patient onto their side, those actions can literally alter the trajectory of a child's life. So as you head into your next quiz or a fast-paced clinical environment, ask yourself, will you be the one to spot those subtle changes before it's too late? Keep practicing your questions, trust your assessments, and thanks for joining me today.